Thank you very much for introduction. I'll talk on diagnosis and treatment of three most important primary headache. This is my disclosure, and I start with the diagnosis. Diagnosis of headache basis ICH3 criteria, which is freely available from the International Headache Society website. And also, migraine is diagnosed based on the ICH3 criteria, and depending on the frequency of occurrence, migraine can be divided into episodic and chronic migraine. Accompanying aura in 30%, they are classified as migraine with aura, and if fulfilled all but one criterion of migraine, they are classified as problem migraine, which is very common in Asian population. This is migraine diagnosis criteria. It is composed of 5 criteria, and 5A, more than 5 attacks per lifetime, typical duration 4 to 72 hours, and typical headache characteristics list 2 of the following: unilateral location, pulsating quality, moderate to severe pain intensity, aggravation by routine physical activity. D, typical accompanying symptom, it is very important, list one of the following: nausea or vomiting, photophobia and phonophobia. E, not better accounted other diagnosis. Migraine with aura, ICHD3 identified aura symptoms as 6 symptoms: visual, sensory, speech, motor, brainstem, and retinal. The 3 visual, sensory, speech are classified the typical aura. However, motor, brainstem, and retinal aura symptom is otherly classified as hemiplegic migraine, and migraine with brainstem aura, and retinal migraine. And visual aura present in 98% of migraine with aura. Therefore, migraine aura without visual symptoms also consider other diagnosis. ICHD defined typical duration as more than 5 minutes gradual onset lasting 5 to 60 minutes. If typical duration is not fulfilled, a higher probability of other diagnosis such as TIA. Chronic migraine is combination of chronic daily headache with frequent migraine. Chronic daily headache is defined as more than 15 headache days per month for more than 3 months. And the frequent migraine is defined more than 8 days of migraine with aura, migraine without aura, or ergot and triptan responsive days. Chronic migraine accounts 90% of chronic daily headache. So they are very important, very common among chronic daily headache. First of migraine diagnosis, nausea is the most common accompanying symptom in migraine, presenting in 85% of patients. A patient presenting nausea with a stable pattern of at least 6 months duration of episode disabling headache has a migraine until proven otherwise. 50% of migraine present bilateral location. Therefore, 50% present unilateral presentation. Having trigger factor is not specific for migraine, but is important clue for migraine diagnosis such as diet, menstruation, stress, sleep, and weather. Tangent type diagnosis. Tangent type is classified into episodic and chronic tangent type headache based on the frequency. If a headache met the diagnosis criteria for both tangent type headache and problem migraine, it is diagnosed as a tangent type headache according to ICHD3 criteria. This is the diagnosis criteria of tangent type headache. And A, attack number more than 10 attacks. B, typical duration 30 minutes to 7 days. C, typical headache characteristics. 2 of the following: 4, bilateral location, pressing quality, and mild or moderate intensity, not aggravation by routine physical activity. D, typical accompanying symptoms, both of the following: no nausea or vomiting, no more than one of photophobia and phonophobia. Tangent type would also subclassified infrequent, frequent episodic tangent type headache, and chronic tangent type headache. Cluster headache. Cluster headache is a unilateral headache for a certain amount of time each day for 15 days to 3 months. Parasympathetic autonomic symptoms on the ipsilateral side of headache during attack. However, 10% of do not present autonomic symptoms. Cluster headache also can be classified into episodic and cluster episodic and chronic cluster headache. This is cluster headache diagnosis. Typical attack duration more than 5 attacks, and typical duration 15 to 180 minutes. Typical autonomic symptom: conjunctival injection or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead or facial swelling, myosis or ptosis. Typical frequency is 1 every other day to 8 attacks per day. Not better counted other diagnoses. Cluster headache belongs to trigeminal autonomic cephalalgia along with the paroxysmal hemicrania, and they can be differed in sex distribution and attack frequency, attack duration, and triggering and the response. Cluster headache is more than male preponderance with 3 to 6 times higher in men compared to women. And the attack frequency is every other to 8 attacks. Attack duration is 15 to 180 minutes. Cluster headache highly triggered by alcohol and nitroglycerin and the circadian circular pain prominent, and also good response to O2 and sumatriptan. However, paroxysmal hemicrania is being equal sex distribution and the higher attack frequency, approximately 10 to 30, and attack duration is much shorter, 2 to 30 minutes, and do not display circadian circular pattern and do not respond to O2 and sumatriptan, but promptly responds to indomethacin. Sanct Suna is being much higher, more than 100 attacks per day, and much shorter attack duration, and do not triggered by alcohol and nitroglycerin, and do not display circadian pattern, and do not respond to indomethacin and O2. All cluster headache require careful imaging, especially an MRI, with contrast and special look at the sella and the posterior fossa, especially pulse on the case. 10% of pulse cluster headache case is secondary, and the 10% of cluster headache do not show autonomic symptoms but have a restlessness and agitation. Treatment, acute treatment principles. Most patients already tried simple and combination analgesics before hospital visit. Migraine patient presenting to the clinic should be given triptan first. Medication for acute treatment are more effective when given early in the migraine attack than later in the attack. To prevent medication-avoided headache, limit the use of non-spacing medication 3 or less per week, or spacing medication 2 or less days per week. Patients who use acute medication more frequently than this should receive prophylaxis. Simple analgesics. Aspirin and acetaminophen are simple analgesics, and they are first choice for mild to moderate migraine. Sufficient dosage is very important. Take half of maximal one-day dose at a single attack. Maximal daily dose of aspirin is 1,000 milligram, and acetaminophen is 2,000 milligram. Therefore, try aspirin 500 milligram and acetaminophen 1,000 milligram. Ibuprofen, naproxen, tolfenamic acid, diclofenac, NSAID, they showed similar or more effective than simple analgesics. Identifying the characteristics of a triptan is very, very important. There are 2 kinds of triptans: L-triptan, rizatriptan, zolmitriptan, and sumatriptan, and almotriptan are rapid onset, short half-life, more side effect. And in contrast, probatriptan and naratriptan are slow onset, longer half-life, less side effect. If patients have been not achieved pain freedom at 2 hours by injection of almotriptan, try the more strong, such as sumatriptan or zolmitriptan. If patients have been side effect at taking almotriptan, consider more mild triptan, such as probatriptan and naratriptan. Tips for acute treatment: combination of NSAID with triptan, half dosage of 1 day maximal dose of NSAID with triptan, rapid onset of effect, and increased analgesic effect may be effective. Try 3 times and consider the change of medication. Side effects of triptan are chest discomfort and burning sensation or drowsiness, and the target of treatment is 2-hour headache free. If patient not responded, take one more time 1 hour after. who are candidates for preventive treatment. Recurrent migraine causing significant interference with the patient's daily life despite acute treatment. It is common for patients who make judgment that symptom control is not sufficient. Frequent headache, 2 or more headache per week or 8 or more headache attack per month on average, contraindication of acute treatment such as cerebrovascular disease and non-response to acute medication or need to overdose, side effects, patient preference, and a rare form of migraine. Principles. Preventive treatment is not substitute for acute treatment. It is conducted in addition to acute treatment. Try each drug for a sufficient period of time. The effect starts usually after 2 to 3 weeks, and don't stop too early, as it can take 2 to 3 months for a maximal clinical effect to appear. Consider tapering the drug after at least 4 to 6 months of continuous use after therapeutic effect appear. If headache frequency increase after tapering, resume preventive treatment. Preventive medication classes are 5. A. Anti-epileptic drug, topiramate and valproate. B. Beta blockers, propranolol, atenolol, nadolol. C. Calcium channel blockers, flunarizine and sinarizine. D. Antidepressant, amitriptyline, nortriptyline, venlafaxine. Others are candesartan, coenzyme Q10, and magnesium. Choice of preventive medication. For young women, topiramate and beta blockers may be preferable. Elderly patient, valproate. And having insomnia and myofascial pain, amitriptyline would be recommended. And diabetics, asthma, avoid beta blockers. For elderly patient, they have high frequency of diabetes, asthma, dizziness, dry mouth, and cognitive impairment. Avoid beta blockers and amitriptyline. Paresthesia on topiramate, beta blockers, and valproate, and chronic migraine, topiramate, valproate, and Botox. Having sleepiness on amitriptyline, but having myofascial pain, nortriptyline can be alternative for this condition. Having hypertension, candesartan and atenolol can be considered. New migraine treatment, Botox treatment, effective in chronic migraine patient. However, is not effective in chronic tangent type headache. 155 fixed site, fixed dose injection and additional 45 unit injection based follow the paradigm based time according to injector decision. Response rate is 50% in first injection, and the 2 additional injection increased the response rate to 70%. A recent study revealed effectiveness in high frequency episodic migraine. CGRP monoclonal antibodies. Up to date, 3 monoclonal antibody and 1 monoclonal CGRP receptor monoclonal antibody are being used. All over 4 are effective in chronic and episodic migraine by monthly or quarterly injection. Key findings of anti-CGRP monoclonal antibodies in migraine preventive treatment. Effective both in episodic migraine and chronic migraine. 15 to 20% of super responder, decreased more than 75% reduction in monthly migraine days. Surprisingly, headache free in 10%. Onset time 2 to 5 days. No dosage adjustment is needed. 50% reduction in monthly migraine days in 50% patient. No response is 25%. It means that 75 response rate regardless of previous failure. If unresponsive to one drug, switching to other monoclonal antibody provide additional response in 1/3 and half of patients. Side effect, constipation, alopecia, injection site reaction into 5 to 20%. CGRP receptor antagonists are named as GFANT. GFANT are used for acute treatment. They is not no vasoconstrictor and they show pure adverse reaction and possibly a longer action than triptan. Therapeutic gain for GFANT is 5 to 70%. Seem to be low compared to sumatriptan and lasmiditan. Previous trials of GFANT causes concern regarding hepatic toxicity. However, new GFANT, including rimegepant, ubrogepant, did not show hepatotoxicity, not constrict cranial arteries. Clinical implications for GFANT in acute treatment are for acute treatment in patients with cerebrovascular disease, since triptans are contraindication for cerebrovascular disease. For patients unresponsive to triptans or unavailable due to side effect. GFANT for preventive treatment. Daily atogepant or every other day rimegepant showed similar efficacy compared to anti-CGRP monoclonal antibodies. No medication overuse headache and oral route available in USA for the preventive treatment of episodic and chronic migraine and will be available soon in Asian countries, including Korea. Lasmiditan. Lasmiditan is a 5-HTF agonist, no vasoconstriction. Side effects are sleepiness and dizziness in 10 to 15%. Similar efficacy to triptan. Clinical implications for lasmiditans are for patients with cerebral vascular disorder, for patients unresponsive to triptan. Tangent type headache treatment. Acute treatment, simple analgesics and NSAID used the same as for the migraine. In other words, try half of maximal dosage and triptan. Triptans are not effective in the tangent type headache patient without migraine, but are effective in tangent type headache with migraine. Frequent tangent type with disability, consider preventive treatment for 3 to 6 months, but could be longer. Amitriptyline is the first line of preventive treatment chronic tangent type headache, 5 to 20 milligrams before sleep, effective both for episodic migraine and tangent type headache. Nortriptyline is less sleepy but similar effect. Mirtazapine and naproxen may be the second line of treatment and showed efficacy in small sample size randomized controlled trials. Topiramate, valproate may be used they only showed efficacy open label study but not in the RCTs. And the duloxetine and the tinanidine may be considered. Cluster headache. Cluster headache is acute treatment of cluster headache composed of 3. Acute treatment, treating when headache attacks. Transitional treatment, reducing overall activity of disorder. Short-term treatment, preventive treatment, using verapamil, lithium, topiramate, and valproate, and galcanezumab. Acute treatment, cluster headache, nasal spray or sub-Q injection of triptan may be first choice, but not available in many countries. Alternatively, use potent oral triptan such as zolmitriptan or sumatriptan. O2 therapy, use non-rebreathing mask, 100% O2, 6 to 12 liters per minute. Response rate is 70% within 15 minutes. Steroid treatment in cluster headache is named transitional treatment. Can be used oral steroid and great option nerve block with steroid. Oral steroid start prednisolone 60 or 50 milligram per day, 6 for 3 days, decrease 10 milligram in every 3 days. Great occipital nerve block with steroid is using lidocaine or dexamethasone. However, other steroid and other local analgesics can be used. Similar efficacy in oral steroid and GOMB with steroid. Preventive treatment, verapamil, start 80 milligram BID or 160 milligram BID, increase up to 400 milligram a day, may cause AV block, EKG before and after use. Constipation is common. Lithium is a strong effect and 300 to 900 milligram can be used. However, follow with electrolyte and blood level. Melatonin, 5 to 10 milligram may be used, but can cause sleepy use at nighttime. Topiramate and valproate can be used. Galcanezumab is showed efficacy and approved FDA for the treatment episodic cluster headache, and also can be used. And also the epicinezumab and eredumab is under clinical trial for the treatment of chronic cluster headache. Summary: migraine is the most common headache type in patients visiting clinics. Consider preventive treatment if acute treatment does not provide sufficient symptomatic relief. Since 10% of first onset cluster headache is secondary, all cluster headache require careful imaging, especially first-onset cases. New treatment of migraine and cluster headache provide better control of this headache. Yes, the Internet Headache Congress 2023 will be held in Seoul between the September 14 to 17, and updated updated information on diagnosis, treatment, and pathophysiology will be discussed. And Vietnamese and most of ASEAN neurologists can be accessed free of charge virtual registration. And also that the headache and neurology specialists from Vietnam can join Internet Headache Congress free of charge as an associate member. They can have been accessed the ITS website learning center for videos, podcasts, and online headache courses, and access to deep back files of nephrology and the neuroscientist journal. And for juniors, benefits from fellowship and grant and educational events. Thank you.